And welcome to the Dr. Bob Show. Cardiovascular disease is the leading cause of death in the United States, both for men and for women. Despite that, men and women have different symptoms with their heart disease. Why is that? How can we recognize it? What are those symptoms? We'll be spending most of this show talking about that. My guest is Dr. Jeffrey Johnson. Dr. Johnson is a board-certified cardiologist, and he'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about the importance of a good night's sleep and what happens if you don't get adequate sleep, and a common cause of blindness, macular degeneration. Can it be prevented? Can it be treated? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Jeffrey Johnson, board-certified cardiologist, and we're talking about chest pain in men and women. Jeff, welcome to the Dr. Bob Show.
It's good to be here.
Tell me about classic heart attack chest pain that people have.
There's varying degrees of chest pain. The so-called Hollywood heart attack that you sometimes see referenced in the literature is the severe chest pain. It goes down the arm, you break out in a severe sweat. It doesn't take a cardiologist to know that you're having a heart attack if that occurs. That's the big one, we like to sometimes say, but the chest pain can be very mild, and I'm sure we'll talk about that. It's varying degrees of severity of chest pain that we usually see with heart attacks.
Where is the chest pain located, and what does it feel like usually?
It's interesting, patients often say, where is my heart? Why would I hurt on the left side or in the middle? It's a bit difficult to explain. The heart's in the left part of the chest usually, but the chest pain is almost always mid-sternal, right in the center of the chest, rather than on the left side of the chest.
Is it a sharp shooting pain, or is it a squeezing pain, or like an elephant stand? How do you describe that chest pain?
Many times patients describe it as a dull heaviness. That's the most classic presentation. It's rarely sharp. It's not always severe. It's more of a heaviness, like I said, or a dullness rather than a sharp, severe chest pain.
Do people frequently know that something's going wrong?
That's a great issue that we need to talk about, because even in this day and age, with heart disease being the #1 cause of death that you talked about, patients have all kinds of different symptoms, and patients are frequently confused about whether this could be my heart or not.
One of my good friends was an athlete, a football player at college level, had chest discomfort, went out to the track to run through the chest pain to get rid of it, dropped over and died. So you have to pay attention to chest pain.
Yes, you do.
How do you know if we just have a chest pain, how do you know if it's the one you need to pay attention to?
In general, we always look at the risk factors that I know that most of your audience is familiar with: high blood pressure, diabetes, smoking history, obesity, sedentary lifestyle, and a family history of heart disease. If you have a combination of those things and have chest pain, I always think it's safest to be evaluated by a physician.
And the evaluation, if somebody has those risk factors, high blood pressure, diabetes, elevated cholesterol, sedentary lifestyle, all those things, what's the evaluation include? What do you do?
We still start with a good history and physical. Most of the time you're going to get an electrocardiogram or an EKG, and then depending on the degree of worry, I guess, that the physician has, we may proceed with some sort of stress testing, or even referral to a cardiologist for more invasive testing.
Do women have different chest pain than men?
In general, women have more atypical symptoms, we usually say. By that I mean women more frequently can have abdominal pain rather than chest pain. Only shortness of breath, nausea, fatigue. Now, I always say if you have those symptoms, it doesn't mean that you're having a heart attack. But if you have those risk factors and there's not a good reason explained for those symptoms to be present, you might want to have your heart evaluated even though you're not having the classic chest pain.
Is there a reason why women have different atypical chest pain than men?
In general, the women's heart disease onset is later in life. Menopause has something to do with that, and female hormones has something to do with that. The size of their arteries is different. The size of the heart is different. Women's nerve endings is different within the chest wall itself. And so the presentation, along with their anatomy being somewhat different, is part of the explanation as to why their symptoms are different, and then the rest of it we don't really know.
Many years ago, it used to be that we would say women didn't get the attention in heart disease that men got, that men were hard driving, hard working, and we paid attention to their heart disease. And more, we pay more attention to women. Is that correct?
I think that in the last 10 to 15 years, we've done a better job at educating the public, in addition to educating healthcare providers, about the fact that women's heart disease is very much prevalent, and as you mentioned at the beginning of the show, the #1 cause of death in women in addition to men as well.
Women get heart disease later on than men, frequently. Is it more severe than men? If they get a heart attack at age 50, is it different than if a man gets a heart attack at 50?
It's very interesting to note that if you are a young woman and have a heart attack, your prognosis is worse than if you are a younger man who has a heart attack, and the reasons for that is not entirely worked out. If you looked at age across the spectrum, young to old, in general, the women's heart disease manifests later, and so they have other medical problems present, and so their prognosis is generally worse than it is for men.
How do you recognize, what do you tell people to do? At what age should they start being evaluated for heart disease? If it's a leading cause of death, how do we handle that? How do we prepare somebody to have a healthy heart later on?
We look at those risk factors. We look at the blood pressure, the diabetes, the cholesterol. I like to say to patients, you need to know your numbers. Know what your blood pressure is, know what your blood sugar is, know what your blood cholesterol is, so that you and your physicians can work on reducing your risk. The age that we start to do that, and it's variable depending on family history and things like that, in general for men around age 45 is the age that we really think you ought to be evaluated for heart disease if that's not been done before in your lifetime. And in general, women age 55. If you're a diabetic and a woman, you lose that 10-year benefit, and also if you're premenopausal or early menopause, you lose a little bit of that benefit that you have over men.
Let's talk about those risk factors. High blood pressure. Why is high blood pressure bad for people as far as having a heart attack?
High blood pressure is where the systolic and the diastolic, the top number and the bottom number, are both elevated, and it makes the heart work harder. So the heart working harder, it's a muscle, it needs oxygen, so if it's working harder because of the high blood pressure, you're putting more strain or stress on the heart, increasing the risk potentially of having a heart attack. Also, the high blood pressure causes that plaque buildup in the arteries that supply oxygen to the heart, and that's worrisome also.
Those plaques that are there, they're in the coronary arteries. Tell me about the coronary arteries.
I usually say the heart's about the size of the fist. There's a major artery on the front, there's a major artery on the back, and the one on the side. They all have branches, but those are the major large arteries that supply the heart muscle.
And if they get a plaque, the danger of that is what?
If the plaque progresses, what we worry most about is the plaque rupturing. A plaque can go from 20 to 30% narrowing of the artery to immediately 90 to 95%, and that's how you develop what we call an acute coronary syndrome or unstable angina or even a heart attack.
If somebody has acute coronary syndrome, that means they're having a heart attack?
By definition, an acute coronary syndrome can mean a small heart attack or what we call unstable angina or angina, and may not be a heart attack, but it's a very strong warning that one could be imminent and one needs to seek medical attention quickly.
So the importance of that, if somebody is having one of those plaques that ruptures in a coronary vessel, is getting to the doctor quickly? Why?
If you get to the doctor quickly, we almost always proceed with what we call an invasive investigation, meaning a cardiac catheterization. If there's an unstable plaque that has ruptured, It's now 90 to 95%. Frequently, we can treat that with blood thinners and then what we call stenting, where we go in and open the artery with the balloon and place a scaffold in there to open that artery and restore blood flow and help prevent damage to the heart muscle.
Is there a length of time that when we have the chest pain that we need to get to the emergency room?
The quicker the better. If you're having a large heart attack, we really want you to be in the emergency room within an hour from the onset of severe chest pain. Our studies show that we need to get that artery open ideally in the first hour. After that, we try to get it open within the first 3 hours.
Is it difficult doing a heart cath with somebody having a heart attack?
It's difficult, but on the other hand, it is the standard treatment today, the best treatment for someone having what we call an acute myocardial infarction, which is, for lack of a better way to say it, that big one that we talked about a minute ago.
And that's what we're going to be talking about when we come back. If you're having a heart attack, acute coronary syndrome, and you have to have a heart cath, what is actually done to reestablish the blood flow? Is it a stenting? We'll talk about that when we come back. We're talking with Dr. Jeffrey Johnson, board-certified cardiologist. We've been talking about chest pain in men and women, chest pain that would indicate a heart attack, what happens when you have a heart attack. Jeff, let's review about the importance of getting to the emergency room quickly if somebody thinks they're having a heart attack.
If there is any question whatsoever, emergency medical services should be summoned 911, because if we have a clogged artery that is cutting off blood supply to the heart muscle, we want to get that opened up as quickly as possible.
When you dial 911, what if somebody was right by there and you just said, take me to the hospital? Better to have an ambulance take you?
We believe it's better to have an ambulance take you because our paramedics can provide monitoring that might need some sort of intervention even before you get to the hospital.
Aspirin?
Aspirin is always a good thing. I think it's amazing that much of the public is aware of that. You'll have people who come to the hospital and say, as soon as my chest pain started, I chewed up an aspirin, and that's always a good thing.
I think it's amazing when people tell me that, because they are more and more educated every year concerning this. They come to the emergency room, they're having chest pain, the electrocardiogram looks abnormal. What's the next step?
In a large tertiary care medical center like at UT Hospital where I work, the cath lab staff is activated 24/7, 365 days a year, and we actually try to get that person to the cath lab as quickly as possible to, again, do an emergency heart catheterization to try to get that artery open and restore blood flow to the heart muscle.
What's it like doing a cath?
Well, after you've done several thousand, it becomes routine, and I try to remind myself that this is someone's life in the balance here, and to remain calm and work steadily. But with the great team of people that we work with in the cath lab, I don't want to say it's routine, but it's commonly enough done that we feel fairly comfortable doing that.
So what you're doing with the cath is you're trying to identify these three main arteries that you talked about?
That's exactly right. With the catheterization, we look at all the arteries, but we instantly on an x-ray screen can see the blocked vessel and can usually see what we call the culprit blockage that needs to be addressed quickly.
Is it more common for somebody to have one vessel that's the culprit, or two or even three vessels that are blocked?
It's not uncommon to see all three vessels to have some sort of blockage, but the chance that we can identify the culprit vessel is pretty high. And most of the time we attack that one at the time. Sometimes if there is another severe lesion present and the first lesion is treated pretty quickly and easily with a stent, we might go ahead and address the other ones while we're there.
If you do a cath and you find that one of the arteries is blocked, what is happening to the heart during that period of time? That blood vessel supplies blood to the muscle. If it's blocked, that part of the muscle doesn't get blood supply, so it dies?
It doesn't necessarily die. There is a term that we use called stunning, S-T-U-N-N-I-N-G, where it temporarily looks like it might be dead, but if you can restore that blood flow, amazingly, the heart muscle function, even in that area, will return to normal or close to normal.
So that's the key to why you want to get the patient that's having chest pain to the emergency room, 911, to the cath lab, so that you can identify. Now, if you have one vessel that's blocked, what are you going to do about it?
Most of the time today, we can treat that with stents. I've been in training long enough that I even remember pre-stent when we did just balloons, but now even in the setting of a heart attack, we can put in a stent to open up that artery and restore blood flow.
Now, what is a stent? I always think of a stent as like a slinky that you put in a blood vessel. What's it like?
It's a great description. It's like a bit of scaffolding that goes inside the artery and actually tacks the artery open after you've opened it up with a balloon.
When you put in a stent and it opens up, do you have to worry about that stent? Does it always stay open? Are there some problems with it later on? How long does it stay open? Tell me about those stents.
Well, the treatment includes not only putting the stent in, but then pharmacologic therapy, in other words, medications. The medications that we use are extremely important to help prevent what we call stent thrombosis, where the stent can clot off emergently, or restenosis, which is less common today, where it partially closes up within the stent. We use aspirin and then more fancy platelet inhibiting drugs such as Plavix being the most common one to help keep those stents open. And the duration of time that we do that depends on the type of stent, the location of the blockage, and usually whether the patient did have a heart attack or not.
When you have a stent, does it completely revascularize? Does it completely put blood flow back to where you want it?
For practical purposes, yes.
And what do you do about the other vessels? What do you do after you've done the stent and the person goes back to the room? What are your instructions to those people? What are they allowed to do?
I always say to patients, look, it's fun and glorious to do this amazing procedure, but now the real work starts, and that's in regards to long-term prevention, with the goal being that we're not back here doing this acute intervention again, and that's working on smoking cessation, beginning an exercise program, blood sugar control, cholesterol control, blood pressure control. Those are the things that we are going to be hopefully following for the next 1 year, 10 years, 20 years, and beyond.
What does exercise do?
Exercise helps reduce blood pressure, it helps improve blood sugar, helps reduce our cholesterol over time, improves our mindset and our well-being, all kinds of benefits to exercise.
Do you worry about, if somebody's just had a heart attack, do you worry about too much exercise too early? What do you tell somebody to do? How do you figure out how to get them on a rehab program?
First of all, I usually tell my patients light walking is fine immediately after going home from the hospital. Secondly, we like to see them back in the office, and if their clinical condition warrants, we refer them to cardiac rehab. Most hospitals have wonderful cardiac rehab programs. The data is very clear that cardiac rehabilitation, in other words, exercise in a supervised capacity, at least in the first 6 weeks to 6 months after the heart attack, is most beneficial for the patient.
If somebody has a heart attack, they have a cath, they get a stent, open up the blood supply, go through cardiac rehab, what do you expect to happen to that patient if it's a man versus a woman, or over the next 10 years?
I think in that case, it doesn't really matter if it's a man versus woman. We look at things such as heart muscle function, if we've been able to preserve the heart muscle function, and then we look at how well the patient responds to the coaching, for lack of a better way to say it, in regards to working on their risk factors. And I tell patients, my goal is that 10 years from now, we'll be having an annual follow-up or every 6-month follow-up, and we'll look back at this event and we'll be thankful for the fact that you've done well. That really is what we hope for in medicine today.
Sometimes it's an awakening. Somebody has a heart attack, they survive it, they do well, and that really makes it where life is more enjoyable over the next 10 years. It gives you a wake-up call.
Absolutely. I tell patients, you can make the change. You've been given this opportunity to make that change, or you cannot. And I have to say, if you don't make some changes, if you don't wake up, we might be doing this again sooner rather than later.
How do you evaluate somebody 8 years later? What do you do? They've had a heart attack and reestablished blood flow. You just keep watching the blood pressure, smoking, diabetes, activity?
We look at all of those things, some of those things being things that we can measure by examination, such as the blood pressure or blood work. We talk about patients and their exercise capacity, and eventually down the road, there is a place for repeat stress testing, echocardiography to look at the heart muscle function and look at the valves. It depends on what you went through the very first time, how aggressive we are at doing those tests down the road.
Jeff Johnson, you're an excellent teacher. Thank you for coming to the Dr. Bob Show. telling us what the different kind of chest pains there are and how important it is to get something done right away. You're a great teacher.
I am honored to be here. Thank you.
Great discussion. Know that if you have chest pain, it's important that you get to the emergency room quickly, 911, chew one aspirin, and get there as quick as you can if you think that chest pain has to do with your heart. And now you want to stay tuned. We're going to be talking about a form of blindness, macular degeneration. Can it be prevented? Can it be treated? And the importance of a good night's sleep. I want to thank Dr. Jeffrey Johnson. Wonderful discussion about cardiovascular disease and its recognition in men and in women. Thanks, Dr. Johnson. Now, questions from you, the viewer, that I think will be important to your health. Question number one, Dr. Bob, is there treatment for macular degeneration? Well, let's talk about macular degeneration. There's an area in the back of the eye, in the retina, called the macula. That's where the central vision is. So as I'm looking at you, the center part is the part of the eye that receives vision centrally. That's the macula. There are two things that can go wrong in the macula, essentially. Age-related macular degeneration. As we get older, everybody's macula doesn't perform as well as it should, and eventually, many people will get degeneration in that part of the retina. The other part, not as common, it's called wet form of macular degeneration. That's where new blood vessels occur behind the macula and can cause dysfunction there. The wet kind can be treated with several types of either laser or photocoagulation. Your ophthalmologist will be able to guide you into the proper treatment for those. As far as the dry type, there's a question of maybe certain types of vitamins may keep that from progressing rapidly. I think the importance of macular degeneration is that everybody recognizes they need to see their eye doctor once a year and have an eye exam. They can then find if there are cataracts, if there's glaucoma, if there's disease in the retina or problems with the eye. So be sure you get that yearly check. If you do get macular degeneration, follow the guidelines of your doctor. Question number two, Dr. Bob, I never seem to get a good night's sleep. What a loaded question. The National Center for Sleep Disorders says that people in the United States don't get enough sleep. And if we don't get enough sleep, it harms the body. If we keep animals from sleeping, they die. If adults don't get enough good sleep, then the body is challenged. The adrenal gland says something's going on, and we can get high blood pressure, we can get insulin resistance and type 2 diabetes, we can get automobile accidents from lack of sleep. So what can we do to get a good night's sleep? Well, sometimes it's too much caffeine, too many cigarettes, too much alcohol. All of those things can interfere with a good night's sleep. Pain can interfere with a good night's sleep. So if we want to get a good night's sleep, we need to recognize that the bedroom should be nice and dark. It should be cool. We should slow down before we go to bed. When we close our eyes, it should be in a restful thinking, not thinking about what we have to do the next day, and allow ourselves to drift off to a good night's sleep. How much sleep do we need? Well, if you're preteen age, you probably need 8 to 10 hours of sleep a night. As you get to be a more mature adult, you need 7.5 hours of sleep. The things that interfere with sleeping are insomnia. Some people just can't get to sleep, or they wake up in the middle of the night and can't go back to sleep. Obstructive sleep apnea, people that snore, that stop breathing for 10, 15, 20 seconds, those people do not sleep well. If the other person in the bed snores, that may keep you from also getting a good night's sleep. A burning sensation in the legs, restless leg syndrome, or narcolepsy, people that just stay drowsy all during the day. If you're not getting a good night's sleep, talk it over with your doctor. It may be that a sleep center is the best thing for you. That's all the time that we have for this show. Now remember those 4 things that we like to do. The first thing is exercise. As Dr. Johnson said, exercise makes us feel better. It will reestablish new blood flow to the heart. It lowers the blood pressure. It will make us healthier. We lose the weight that we want to lose easier. Start that day off with 7.5, 8 hours of good restful sleep. Know that sleep is so important, and if you're not getting that good sleep, work it out with your doctor. Eat properly. Remember, what we eat is how we are. So start the day off with a good breakfast, a breakfast with fruit and fiber. Make every meal as we go on less large in size. Look at your plate. It's usually portion size in the United States that causes us to eat so much. So look at the plate before you start eating and say, this is all that my stomach needs. If you get hungry in between meals, eat a very small snack. You'll be able to satisfy those hunger needs, and you'll find that you'll actually lose weight. And most of all, what is it we like in the Dr. Bob Show? Is that laughter in your life. I can't emphasize how much laughter means to everybody. They'll feel better, they'll perform better, people around them will feel better. There's nothing like laughter. So find that person that you like to giggle with, tell the same old stories and laugh on them, and the more you laugh, the healthier you'll be.